Good morning, welcome back. This is Daybreak and thank you for staying with us. We now shift our attention to what will happen on Friday at the Green Stadium in the county of Kericho, where President William Ruto will preside over the Mashujaa Day celebrations and in the county of Kericho, and the country's commitment to have universal health care by 2030 and the Kenya Kwanza government's plan with regards to how that can be attained. But first we begin with this report by Safina Cheng Ouma, who sets up our discussion. And the president, who will jet back from China into the country, will assent to the Health Digitalization Bill of 2023 by Thursday, a day before the celebrations that will be held in Kericho County. According to Health CS Susan Nakhumicha, the bill will ensure access to real-time and steer data-driven health outcomes and solutions in the country. The CS has also revealed plans by the government to establish the National Health Digital Superhighway to improve the management of health records, products and technologies across the country.
The UHC conference happening in Kericho County entered the second day today, with discussions on digital health innovations taking center stage. Speaking at the sidelines of the event, Health Cabinet Secretary Susan Nakhumicha has revealed plans by the government to establish a National Health Digital Superhighway to improve the management of health records, products and technologies. According to the Cabinet Secretary, lack of timely and reliable data has been a major impediment in achieving proper health outcomes.
We want to ensure that we create an interoperable environment where all service providers or all stakeholders within the health sector can be able to connect on a digital superhighway, so that then we can be able to share records, we can be able to share information across, we can enable patients to access their information.
Nakhumicha also revealed that President William Ruto is expected to assent to the Digitalization Bill of 2023 by Thursday this week to bolster efforts to adopt technology in health.
One of those bills is the Social Health Insurance Bill. And that health bill has repealed NHIF, that has been primarily the one that is in charge with the healthcare financing. We have repealed NHIF, but we are starting what we call Social Health Authority. So this authority is going to ensure that, one, it provides financing for primary health care that will be publicly financed for primary levels. Then we shall have a social health insurance where you register or you sign in, that members shall be onboarded.
Acting Director General of Health, Dr. Patrick Amoth, cited that digitalization of health records is a key pillar in UHC implementation.
And if we can be able to leverage on technology, we can create synergies, efficiencies, and effectiveness in delivery of our healthcare system.
The ministry also seeks to invest a huge percentage of the 18.4 billion shillings set aside for UHC implementation on human resource for primary health care.
So our priority as a ministry, and that amount of money is not enough to provide healthcare, but it is sufficient enough to ensure that we invest in promoting wellness and preventing diseases.
The 4-day event is bringing together various stakeholders, showcasing innovative solutions for challenges in access to health information and records.
Murang'a ndio kaunti ya kwanza kufanya ile inaitwa automation ya health records, yani kufanya rekodi za patients zote ziwe katika maneno ya digitali.
The conference enters day 3 tomorrow, with the stakeholders set to discuss the pertinent issue of health financing and how to bridge the resource gap in the implementation of universal health coverage. Safina Cheng Ouma for Citizen TV from Kapkatet Stadium in Kericho County.
And it is at the Kapkatet Stadium where President William Ruto on Friday will preside over the celebrations to mark Mashujaa Day, the second since he took over office in September 2022. And it's themed the path to universal healthcare coverage. The Health Digitalization Bill was what the CS Susan Nakhumicha spoke about with my colleague Safina Cheng Ouma, who is in Kericho County. We are now joined from Geneva in Switzerland by the Kenya Medical Practitioners and Dentists Union Secretary General, Dr. Davji Atela. Good morning, Daktari, and thanks for making time for the broadcast. Talk to me, because this is a wholesale sort of what we'll be discussing here, of the significance of the digitalization bill that the president is set to send to as the first task when he gets back to the country from China. What's the significance?
Yeah, thank you so much, Abdi Kadir. And many a times people will give promises, but we say that people with good intention give promises, but then people with good characters keep them. I know that this new government has really unveiled very, I would say, magnanimous and good promise in healthcare, and this is seen with the bills that are put in place that are ready for assenting. And if you look at the aspect of the digital bill, essentially it is to make it easy access, easy data, easy communication, easy retrieval of the patient history. And I think this happens in quite a number of developed countries where they do not only use now the paper or the ad paper materials in management of patients, but nowadays it has gone digital and it makes it quite more efficient. The only problem is about actually implementing it and making it work. So as it is now with the digital bill and the prospect of digitalizing healthcare and its management within the country, if the bill gets assented and gets implemented, then the overall outcome of healthcare management will actually improve in the country. Mm-hmm. So the question is just the part of implementation. We know very well that with the digitalized healthcare system, that, for example, the one in India, it's very easy that if you go to a hospital in any part of the country, you can then easily, the doctors who are in one part of the country can actually access the information, can retrieve the history, can have efficiency in management, compared to a place where you have to start the old processes afresh, because it means that all your records, all the data, all the procedures that have been taken to a patient are easily managed.
Okay, Dr.
So that is a good...
Okay, we'll talk about the commitment, because it appears that it's there, but the pathway is Kenya to become a universal healthcare coverage, covered universally in terms of its healthcare systems by 2030 amongst the UN member states. Talk to me about whether that is attainable and the achievability of that in under 7 years' time.
In attaining the universal healthcare, it means that, that all the Kenyans should be able to access healthcare without worrying about the financial burden. The Kenya should be able to go to hospitals, and you don't have to sell your land. You don't have to go into contributions. It should not go beyond your beyond 10% of your wages to access this care. And therefore, for universal health care to take place, there has to be the pillars that have to be looked into very strongly. I know there's quite a lot of talk about the primary health care, which is one of the pillars that the country has set forth for the universal health care. And when you look at the model we have for the primary health care, we've just gone into the aspect of health promotion. And I keep saying that community health promoters are not healthcare workers. And why are we saying that? Why am I saying that? Their actually role is just to promote the access to care. They just need to advise the public that fine, you've been you're diagnosed with diabetes, you're diagnosed with hypertension, you need to go visit the facility. So actually, in that case, there should be functional facilities, level 2s, level 3s, level 4s, and level 5s in the country. That essentially is the role of community health promoters, and also to actually advise the community on the social determinants of healthcare within the country, within the community, the level of hygiene that they need to have to prevent infections within the community. That's essentially the role of community health promoters. I would actually put it as synonymous to somebody who is promoting a drug or promoting a commodity or promoting something within the society. Your role is not actually to do it. If you're promoting Philip products, you are not the manufacturer, you're not the engineer in it. You just tell people more about it. So essentially, the role of these community health promoters is just to link, to promote this healthcare so that the Kenyans can go to the facility and get care or be treated with the qualified or skilled health personnel. So that's one thing that comes out with this aspect of community health promoters. The other thing that is very important to be looked at the pillar of UHC is the human resource.
Okay, we'll come to the human resource question, because generally the welfare of the medical professionals has been a priority for a union like the one that you lead, the Kenya Medical Practitioners and Dentists Union. And we have seen some industrial action that you embarked on, for example, in 2017, the longest in the records. But talk to me about the promoters you talked about and the government has embarked on. Are they important? I mean, they have no medical skills to somewhat exercise what the profession dictates otherwise, for example, for doctors and clinicians. But are they not important in that whole process of establishing a healthcare system from the primary? Their role is not to diagnose or to treat, especially. If you look at the Alma Ata Declaration of 1978, the major thing that was bring about the effect of the primary health workers or primary health promoters was one thing, just to link the aspect of healthcare from the traditional way of the doctor and the hospital setup to make it possible that the members of the community can actually participate in the social determinants of healthcare. What do I mean by this? That you must look at it that somebody who, the members of the community, they need to know about the existence of particular outbreaks. They need, most of the times when somebody has hypertension or they have diabetes, they always buy those the machines for measuring hypertension, and also sometimes they have the strips for checking on their diabetes. So these are things that people can always self-check. But then with the presence of the community health promoters, then it enhances and reminds people in this setup to actually check their pressure, to check their sugar levels, and also to actually check if somebody is in the house and they do not really know that they need to go visit the hospitals. It is the community health promoters that can actually make them visit the hospitals. It has also been used as a patient supportive system within the HIV management structure, whereby the patient adherence to antiretrovirals has always been strongly enhanced by the existence of the community health promoters. They call all the community health workers, whereby when you're on the drugs, you get reminded, you're being told the need, the support, that's why you need to take these drugs and being followed up. So especially, I think that model of the adherence that the HIV system is using to actually follow up patients is what the community health promoters will essentially do in the society, in the community, like to remind people about if you are sick, to actually remind you about the normal and common conditions that you are having. Their role is not to diagnose, their role is not to treat, because they are not skilled in such. And that's why there should be a really functional level, all levels of hospitals. Okay. And when we see in this bill that there's an hub and spoke, whereby they say hub is the level 4. That level 4 should be equipped and functional as level 4. We also see that there's a level 2 facilities and dispensaries. They should be functional with skilled human resource. So with that, then it becomes easier for the community health promoters to actually do their job. Otherwise, what you always say is that you may have people in the society who will be believed to be doctors or clinicians or nurses, but they're not trained as such. And that would actually can actually mess up the whole thing of healthcare. There has to be real clear demarcations of their role. That they're not supposed to treat. They're not supposed to care. They're not supposed to diagnose. Their role is actually to link you to care and to be more of an advisory in health preventive measures. Okay, then talk to me about this, because the ambition is to be to attain the universal health status by 2030. That's in under 7 years' time. We had this rollout in 4 counties piloted by the Kenyatta government in December 2018, and the pilot process ended in December 2019. I mean, but the rollout across the counties, the 47 units, failed. Then what is the achievability scale here in terms of the Kenya Kwanza administration's plan? And this is President William Ruto, one of the mega plans that he had in the plan, which was his manifesto. I mean, how can this be achieved from a key stakeholder perspective? What level of involvement have also been embarked on by the government for you to be involved, for the counties to be involved, for this holistic approach to attain that status by 2030?
If you look at the piloting of the universal healthcare in the 4 counties of Kisumu, Nyeri, Machakos, and one thing that comes out very clearly is that the number of hospital visits actually increased in all those counties, and quite a number of challenges that were observed with that, because the commodities, the consumables are all being utilized. It was more of an input-based approach to the universal healthcare within those counties. And when the country observed those challenges, they were now to extrapolate all this process to all other parts of the country. It is only that they did not look at all the pillars that are necessary for universal healthcare to be realized. And that's why, as much as we see in this new government, they're trying to go through each and every step of these elements of universal healthcare. They're talking about the digitalization of healthcare, they're talking about the health financing, they're talking about the commodities, they're talking about human resource, which are key components. They must be actually functional to realize the healthcare or to realize the universal healthcare, because it means that somebody has to go to an hospital. If you go to Jaramogi Oginga, you need to get care. If you go to Subukia level 4 in Nakuru, you need to get care. So essentially, that's what it means. It's actually just the basics. But therefore, for that to take place, there has to be strong plan. There has to be a planning to ensure that that takes place, which we did not see in from 2018. Yes, there was a budgeting of about 62 billion for universal healthcare in 2021. There's a budget of about 47 billion in 2021-2022. But the intricacies of ensuring that all these pillars are functional were not seen and have not been realized. That's why it was more of a talk. We also keep saying, we've been saying a lot of times that giving a promise is one thing, keeping the promise becomes very important. And it can only be kept when there's actually, all the things are actualized and implemented. We see a very ambitious plan with the Kenya Kwanza and saying that we're going to realize this after the launch of 20th this month. But after that launch, what are the plans that are going to be put in place to ensure that now we have a human resource aspect is sorted out? We have the issue of commodities. Like you see, I think it's yesterday, it's very clear that if you go to an hospital in Meru, you will not get anything. Why? Because the KEMSA had like terminated their contract to them because they have huge bills. And that is just not Meru. It is also in all other counties in the country. Okay. Will that be sorted by these funds? And if you look at the issue of the financing that counties complain about every day, that they cannot handle healthcare because they don't have enough funds, because they have exceeded the Public Finance Management Act, will that be sorted by these particular plans? Okay. So those are the things that we need to look at. And then this digital, the integrated digital bill that is being put in place, how will it be implemented within the county? How will it integrate counties, the national government? Okay.
Dr. We'll discuss the welfare aspect because it's been a concern and a common one for that. But when you talk about the funding question of this entire process, because healthcare is very key for the nation to prosper and to thrive, to attain the height of prosperity needed. But is what we are at the moment allocating enough? I mean, 9%, which is below the Abuja declaration of the proposed healthcare funding of 15%. How then can we gradually increase that increment needed to 15% from the current, which is by addition of 6%? Is that commitment there, and not from the perspective of the current administration, but also the previous ones? Why do you think there has been a failure in attaining that target of the 15% funding?
You invest where you have interest in and where your priority is. And I keep on saying that the investment in healthcare in the country has been actually very low. And I think it has been at 4.4% in 2021, 2022. Now it's a bit more over 6%. Even this financial year, the percentage of the funds for healthcare actually is still very low. I think it's below 7%. So when we want to look to have a functional healthcare, we must look at healthcare as an investment. And that's why in the Abuja Declaration of 2001, it was for each country in Africa, look at healthcare as an investment. And therefore, that's why they have to put either 15% of the annual budget or 5% of the GDP in every year, because then that means that it's going to be functional. Health can never be free. It's either the patients pay or the government pays for it. And therefore, the dysfunctional public health care in the country is always a clear manifestation of non-investments of funds by the government in healthcare, as expected.
All right, Dr. Taril, it takes us to this, because the items that the government had outlined, which includes the the primary healthcare bill, the facility improvement financing bill, the digital health bill, and the social health insurance bill. UHC will be realized according to the government. We have seen how the 4 pilot cases in the counties of Kisumu, Machakos, Isiolo and Nyeri have failed to have the effect across the 47 counties under the Kenyatta government. But again here, talk to me about the triple crisis here the country's healthcare system faces. One of personnel in terms of functionality, 2 in terms of equipment, and 3 in terms of drugs. And recently KEMSA said it's running out of drugs, notwithstanding, of course, its own fair share of problems, including corruption, which has dogged the medical agency. I mean, is that also not a priority area for the administration to address, even as it embarks on this ambitious journey of attaining the status?
If I look at, I started with the part of the drugs. I mean, if you look at the Kenya Kwanza manifesto, it is very clear that they talked about the restructuring in the KEMSA to ensure that there is a seamless flow of drugs to all the facilities in the country. And I think it also forms part of the agenda of the plan for this universal health care. But as I say, that remains a promise before it is implemented. As we speak today, majority of the hospitals, over 80% of them in the country, do not have the essential drugs that are needed to actually operate those facilities. And we have seen now and again many hospitals that will give memo to the different doctors in the facilities and even the nursing units and telling them we do not have this particular essential medications or essential drugs. And therefore, when the patients visit the hospitals, they're supposed to be given the prescription to go buy them outside. So this is quite a common occurrence. It has not been resolved. So there has to be a clear plan on how this will be resolved, especially with the existence of KEMSA. So KEMSA must be funded to be able to have these drugs. And you see, the biggest defunder for KEMSA are the county governments because they do not pay it on time. And again, that makes it very difficult to outflow. So the restructuring should ensure that there are actually drugs within all the hospitals in the country. I don't know how they will do this. They had talked about stopping the monopolization of only procuring drugs at KEMSA. But I think that also may also open some other Pandora box. So we have to look at it in that direction. The other thing that is very important that we must look at is equipment. I think we all know these managed equipment services that are also in the country that has consumed quite a number of billions of shillings in every financial budget for the country. It was there from 2018. Even in the financial budget of this year, about 5.9 billion goes to the managed equipment services. Okay. But that report from it, actually, it was a very good plan. It was to ensure that every county in the country has equipment, that if you need any, the renal equipment, if you need ICU the equipment, that were from a different part of the country, the theater equipment. But now the whole thing was about its rollout. We were seeing a situation whereby this was being pushed down to the county without considering fixed skills of personnel that the counties were having. So in essence, most of these equipments were not utilized and have not been utilized. So without really giving into consideration the need for the personnel necessary for the operationalize of this equipment, then I think it's something that has to be sorted out strongly, the aspect of personnel to actually make them run. Though I know that particular contract is still going on, despite the recommendations from that committee to have the mixed personnel put in place for it. Mm-hmm. That's the part of the human resource for healthcare. I mean, the reality is that, and we have said this, that for the different times that universal healthcare has been launched in the country, we have said it's a pipe dream. We have said it cannot take place. Why? Because there's been a serious neglect to the human resource component, which is actually a backbone for healthcare delivery. You can have the best level 5 hospitals, the best level 7, if there's something like that in the country, but without the personnel to offer the services, there is just a building. Okay,
that then brings me to this question, because there are many doctors who are unemployed and who have graduated with the necessary medical expertise needed. I mean, if the doctors are a key component of this entire process, because they are at the epicenter, they are the nucleus of the plan to achieve universal healthcare status. I mean, this must be done by the professionals. If thousands of them are not employed, why then do you think that's the case, and do you sense the existing appetite to have these doctors on board for them to get this work done? Because if the government plans to roll out all this process, the primary healthcare bill, the facility improvement financing bill, the digital health bill, and the social health insurance bill, then it comes down to the practicalities of these exercises to be undertaken at the medical facilities level, yet you have thousands of unemployed doctors. Do you see the appetite?
There's been, I think, what I will say with this government that was different from the previous one, because there's a sort of conversation regarding the human resource of healthcare for the first time, and we are having talks on these numbers that have been unemployed. And I must say, Abdi, that if the human resource component of healthcare is not handled, then we are still having a pipe dream of universal healthcare. It's a fact that if we have, for example, in the country as of now, we have about 6,000 doctors that are employed working in the government, and we have a population of about 56. So the ratio of the doctor to the patient is still around 1 to almost 10,000. It should, and every year we have about 950 doctors graduating. So therefore, it means that the deficit of doctors in the country is about 50,000. It will take Kenya 50 years to reach the WHO recommendation of the doctor to patient ratio if every year we employ all doctors who graduate. Despite all this big shortage, we have about 4,000 doctors who are employed. It's a clear indication that without health professionals, without the skilled doctors employed, without the nurses, without the clinical officers, without the radiologists employed, then the whole essence of access to healthcare for all is a dream. And that's why it is very important for this government to really put into consideration the matters of human resource. We need to have the level 4 hospitals that are considered the hub to have doctors, to have all these health professionals. We have to consider that these dispensaries, they need to have doctors. Actually, if a doctor opens up a facility that he runs as a clinic by himself, that's considered level 1, like a dispensary, which we're saying here to be a spoke. So essentially, there will be no access to care to Kenyans if we don't have healthcare workers employed. And this has been a problem for the last 10 years. Why am I saying this? In the last 10 years, before devolution, the doctors and all health workers were being employed annually by by the Ministry of Health. From 2017, there has been no annual employment. So most of the counties across the country, if you look at them, they all still retain the number of doctors or nurses that they've had through that time. They have not increased. And there's no replacement of the doctors who die or those who leave the service, who resign, who move through attritions. There's no change to these numbers. And that's why we are saying there's actual dysfunctionality in healthcare within the country.
All right.
We have seen challenges whereby county governments in different parts of the country are complaining about the controllers of budget ceiling that has been put in place. That most of the counties have surpassed that particular ceiling, and they cannot employ any doctors or any healthcare workers. It means that they have come to understand that they cannot offer the healthcare that is much needed. That's why we were saying, and we've been keep on giving the input, that for the government, even the Kenya Kwanza, in the manifesto, they had put it very clear that they will, within 100 days, they will have 20,000 healthcare workers. Why did they say this? Because that was the only way to change the landscape of healthcare delivery in the country.
All right.
So for we to realize this, then that's why we keep on saying we have to manage healthcare in the same way we manage education or we handle security. We must have Health Service Commission, which is funded annually and with an ultimate aspect to show that there's a functional health workforce.
Okay. Dr. But why has it been an exercise, an uphill task for that matter, for the government to employ doctors? I mean, what's the problem? Is there an incapacitation of existing capacity? Where is the problem exactly?
The problem is making a decision with 48 governments. You know, if you have 48 individuals who do not seek care in those particular hospitals that they manage, then the most of the times will give in to a lot of rhetoric and PR to show that those hospitals are functional, even if they're not. And therefore, that's the biggest problem that we have been seeing, because most of the counties are not employing, and most of the counties are not taking care in those particular hospitals. To the point that counties will want to put their health workers in a private insurance because they don't want them to access care in those hospitals because they're not functional. And that's why we have been had a put. If you look at this aspect of the 8,000 UHC health workers that were employed, they were employed by national government. But when their contracts was ending, they were to be absorbed by the 47 governments. You realize that they don't have any plan to do it. We have this plan of 20,000 health workforce. There's still a problem on how do they get engaged. That's why we keep saying something has been tried for over 10 years, and it makes our hospitals to be more dysfunctional. Because counties, in real sense, have really specialized in building new structures every day. Because this can be seen. We have seen a lot of level 4s being built. But without employing the health workforce, without having the personnel to serve those hospitals, then they remain just building. That's why even this dream to have 20,000 health workforce, if it is not well handled, then we will not have them.
Thank you.
I know that this government has tried to put up the care track, which then now is to reduce the intergovernmental politics between national government and the county government that I would say bring a lot of inefficiencies. So with this, probably if those resolutions and the plans that they have are adoptable by both national and county government, then you may see employment of health workers and a functional public system. But if it comes to recommendations that are not enforceable to the counties, then we may still just be in a phase of dreaming. Yeah,
okay, Dr. And I want us to talk about, before I get also the account of the Secretary General of the Kenya Union of Clinical Officers, Mr. Joseph Chabii, with me in studio, on the proposal to have the deductions, because 2.7% is the contribution to the scheme, which is not yet in the proposed bill, but will be, of course, captured in the regulations to the social health insurance bill. And this is set to be capped at a minimum of 300 shillings and at a maximum of 5,000 Kenya shillings. Then, Dr. Davji, is this contribution, will this kitty be, in your assessment, immune to corruption? Because we have seen how corruption literally tore apart the NHIF contribution scheme that we have had as a country. I mean, how do you think this management of this bill will look like, of this kitty will look like once the bill is passed by Parliament?
You know, the biggest problem that National Hospital Insurance Fund has had is the accountability for this particular a fund that the public collects. You realize that majority of Kenyans would not get the care or the cover that they need in consumer rates to their contributions they've been doing, and particularly even if they visit hospitals. That's why the aspect of accountability is very, very important in these particular funds, as much as it's now getting increased. We have seen these enhanced medical cover from NHIF that was covering the civil servants. We found that was actually one of the best insurance, because then it was able to really give the value to the public servants. But those who were giving the normal contributions were not getting the cover that was consummate in terms of getting the services. Why am I saying this? Is because you go to the public hospitals and you are covered by NHIF, and these hospitals that you will go to are not functional, are dysfunctional. So you get forced to go to the private hospitals or to any other place to seek care, and the only rebate that could be paid was the beds, the bed was for the bed. So you end up actually having to contribute more. So that is the problem that was experienced with the National Hospital Insurance Fund.
Thank you.
The only thing with these 2.75%, does it mean that there will be more increased, there'll be increased coverage to the contributors? That's one thing. Number two, if you look at the populations in the informal sector is about 83% of the contributors. What will be the mechanisms that the government is going to use to ensure that everybody is covered? Because the ability to contribute every month is not there for everybody.
Okay. Thank you, Dr.
Contribute just before they get the care.
Okay. Thank you. Now in studio, Joseph Chabii is the Secretary General of the Kenya Union of Clinical Officers. Dr. Davji will be coming to you shortly. Thanks for making time for the broadcast.
Thank you so much, Ayub.
Much appreciated.
Yeah, I'm the Secretary General for the association. Kenya Clinical Officers Association.
Thank you.
Thank you.
Talk to us about this general drive towards universal healthcare? I mean, Dr. Davji and I have talked about issues in regard to welfare, the financing model, the bills that have been proposed, some at the parliamentary stage, and what will be happening on Friday at the Kapkatet Stadium, Green Stadium in Kericho County, where the president will preside over. It's themed universal healthcare coverage in under 7 years that's to be achieved by the country. Do you think we can smoothly be on that path?
Thank you so much, Ayub. And I also thank Dr. Davji. I think he exactly expounded on the pillars of healthcare services. And he was very clear on financing, on how we are going to raise finance. Is it very realistic that we only make the contributions from employees, and that is enough for the Kenyan population? He's very right. It's not possible that we are only going to raise our funds from those who are employed. Ayub, when we talk about universal health coverage, it is something that can be achieved with the taxation, with the resources that we have in this country. It is only the government to realign and give a priority to health services. We cannot talk about unfailing, like at the moment, what is going on, and which is so hype, is about the community health promoters.
Yes.
That does not mean you are achieving universal health care. What we need is that there are steps. When you talk about having the promoters, does not mean Kenya is actually getting the best services. So for the idea that we really need to utilize the workforce which is existing at the moment, we have about 8,000. They are now head to 10,000 doctors. We have about 15,000 clinical officers, over 30,000 nurses who are not employed by this government. So if we have such a number of healthcare workers, the lab and many others, we have them with us. And you are talking about healthcare, universal healthcare, when we've not even absorbed these healthcare workers. You can go to the 2014, I hope they are going to revise on HRH, and you will realize that in a facility in Kenya, there's a very huge gap. If you go to level 4, level 5, in a level 5, what do you expect? How many doctors, specialists, how many nurses, how many clinical officers? As you come down to level 1, to level 2, you will realize we have a very huge gap that we at least need to fill in the health facilities. But going just down to level 1 and now picking the most popular people in the community without even any basic training, and you tell us, you put them on some jackets, and you tell us now, these are the doctors in the village. I think we are misleading Kenya.
Are they insignificant in your view? I'm
not saying they are insignificant. It is, you cannot pick me. Let us also appreciate health is something which is very sensitive. And no wonder people get trained for a long time. We have a lot to learn about a human body. So when you just move in and you pick someone who has no any basics about any handling human beings, and you just put them on jackets, like what is happening now.
I mean,
that one means...
Yes, the qualifications in the bill, if I may.
But do we have...
Kenyan national, above 18 years.
Yes.
No qualifications stated. But as stakeholders, when you were engaged by the government, have you raised alarm over this? Because that informs generally keeping of records, I mean, visitations to be done by the primary healthcare promoters. And they are very critical in the sense and have no qualification.
The question I'm asking you, who is visiting you? It's a layperson who is visiting you. If the government was very serious about this issue, it's very clear. One thing, you reorientate. Why can't you have them learn even like an institution like in KMTC, even for 6 months or 1 year? Train them on health promotion. Health promotion does not mean you go and prick my hand, you do other things. like even taking my blood pressure, like you want to prick me, the whole of that kit, it needs someone who is skilled.
As an association,
yes.
Did you meet the government over this? Because you're key stakeholders.
But this is all that we usually say. But
you mean there was no engagement level? I mean, nothing was done in terms of consulting you?
It is not about even engagement. It is about engaging and making implementation. It is very clear. And why are we in a lot of rush that we want them like all over the place? I think the president is misguided. We can implement this universal health care by employing the already skilled health care workers. We have them in the community unit, and we structure them from the senior-most medic, and it just goes down to the health promoters. No one is taking their space, but the alarm we are giving is that how can we have someone who is not trained, a lay person, you have not trained, can we train them? If we are very serious about this, let us have all our health promoters be trained in an institution like KMTC and other institutions for 6, even and above months, so that they can be oriented well on what goes on. And Ayub, before even you go to employing or having health promoters, you have nurses available. Why can you have them in the health unit? You have clinical officers who are available. Why can you also use them in the health unit to be the referral from the health promoters to the same health care workers? We have family doctors. Why don't we have them also in the family unit? The whole ideology of having primary health care devolved to the community. It's a very good idea and a nice one, given if you look at the Cuban way of implementing issues of health care. You realize it is what Kenya is trying to adopt, but they are using the wrong people. Can they move and use the right people in the community health units? Family doctors are there. We have nurses. We have clinical officers. We have laboratory technologies at our disposal. Let us structurize. And if we're going to have the health promoters, let us be very specific to what they're supposed to do. Let us be very clear on their job description so that we don't mess healthcare. We bring down the quality of services we are giving to our people. But the idea of just having a very popular person in the community to run healthcare services, the quality of services are going down.
Thank you. Dr. Adabje, coming to you, should there be then a campaign by the government around, and you, the stakeholders included, of course the doctors are very key, the nurses and the clinicians, should there be a campaign around amplifying the advantages of the cost, the benefits through this scheme, which will outweigh the cost? I mean, the concern is the reductions, of course, and Kenyans are very concerned about that. But shouldn't the government and you, the stakeholders, come out and provide extra information, amplify on the same, expound on the benefits which ought to outweigh the costs in this case?
Yeah, I think that is very, very important because when we have been talking about that as civil servants and even all the Kenyans, the one thing that should come out very clearly that in this social health insurance fund that is being put up in place, we need to be able to help Kenyans access care. We need to be able to make many Kenyans not to stop selling their lands to seek services in the hospitals. Because as we know, the out-of-pocket expenditure in Kenya currently is at about 150 billion. And if this collection is done, is it going to protect the Kenyans from going out of pocket so that they can actually seek care? And that is something that must come out very strongly to help, rather than also having another fund that do not actually help the Kenyans as expected. That is number one. I want to contribute a little bit to this thing of the community health promoters and the misconception that has been seen around it. And I can see also my brother actually brought it out very clearly. There's a confusion of the community health promoters and health worker. And I've said from the beginning that the community health promoters are being put in this regard are not healthcare workers. And we have seen even some governors, and so I think this was in Western, who was coming out strongly, lashing out on the senior doctors and on the consultants, the governor for Trans Nzoia, and actually saying that we are going to replace doctors with the community promoters. You realize a level of ignorance that comes with such particular statements, because then it makes the community believe that the persons that are being brought in are actually doctors. Therefore, there's a lot of ignorance and a lot of not speaking facts on it. The emotive political rhetoric by some governors, because they don't understand. And that actually has ramification on the care provision. And that's why when Chemi is speaking about this, it's very, very important that we should know that the 100,000 are not healthcare workers, are not doctors. Their role is here. The role here is to ensure that there's a strong link between health service delivery in the community and the service and services in the facility. They have a critical role that cannot be downplayed. And that's why in many setups, like in Zambia, in Malawi, and it is a matter that been discussed in World Health Assembly.
Thank you.
It was discussed even in the UNGA. So it's a very important component, but then governors should not be misadvised. We saw a governor from Tanzania speaking very antagonizing the essence of service delivery.
Okay.
And I think that's a lot of ignorance that actually affect the service delivery in these counties.
Thank you.
We also see many counties who, in essence, promised better terms for doctors, for nurses, for clinical officers in the country, like the county government of Nakuru.
Thank you.
But when this came to office, the first thing they do was to change even the terms of engagement. So you see, those are the things that I would say that if they're not handled, yes, we may say the government may have very good promise, the national government, they may have the best plan for healthcare. But if there's no way to synchronize it well with the county government that offer these services, it may just be a problem.
Thank you, Dr.
So we must look at a mechanism that will ensure that healthcare is not seen just as a matter of devolve, because that's the message that keep on coming. When we come to service delivery, we always have this issue of the counties have done very well, the health is devolved. But I can say Kenyans are not devolved, they are not devolved, finance are not devolved, and we must look at it differently.
Okay, thank you. Joseph, we are talking about a devolved function.
Yes.
And what Dr. David highlighted are the fears therein, as you have mentioned, of the promoters at that level. And even as this is a devolved function, how then, in regards of rolling out effectively what belongs to the national government and what ought to be done by the counties to prevent overlaps?
Yes, I think the Constitution is very clear on the functions of the national and county government and how they're supposed to collaborate. So they're supposed to collaborate together. However, the rollout now, we actually have a feeling that we may have some challenges along the way, because how this is rolled in this county may likely be different from this other one. And I think we get misadvised, because you cannot roll the whole system in the whole country at the same time. It's like we are going against the science. We are supposed, as Kenyans, to first of all start from somewhere, and at least to go to somewhere, at least have a start with a few of the counties. We roll them out, we see how it's going to be, and from there now, we can replicate in other counties. Something that I also wish to talk about is how are we going to finance? We all get the money from the exchequer. We cannot continue like now having money from the public servants, and then like now we are headed to about 2.7%. If this bill goes through, 2.7% might not be enough for the whole population in Kenya. It is time Kenyans and Kenya as a country take responsibility and take care of its citizens. Kenya, we are taxed now at over 50% of our taxes. We are being taxed. Go to the Western countries, our taxation and their taxation are at the same level. What makes them provide services to their people, free health care, and we cannot provide?
I mean, they're largely social welfare states. And
yes, social welfare state.
And then in your view, do you think, as we finish up, that this is largely, or this largely comes down to the quality of governance that we have? Yeah,
in fact, if we go to the pillars of healthcare management, I think there is a problem in leadership and governance. And this one goes straight to the management of resources. How are we taxed to 50% and we cannot get services like in other states? So it is a wake-up call to the government that they have resources to support health care, to support all Kenyans, to get free health care without going to continue taxing the already overtaxed Kenyans. So they have a responsibility to create resources for health care.
Thank you. Mr. Joseph Echabi is the Secretary General, the Kenya Clinical Officers Association. Thank you for your time. Of course, this is going to be a conversation that will continue even after Friday, when the President will preside over the Mashujaa Day celebrations from the Green Stadium in Kapkatet in the county of Kericho. And thanks to you too, Dr. Davji Atela, who joined us from Geneva in Switzerland, for your time and the accounts that you have given us here of the country's drive to universal healthcare coverage by 2030. And thank you to you too for waking up with us and watching the broadcast here on Daybreak. The hashtag has been Daybreak. The SMS code 22422 at Citizen TV Kenya and at Ayub Abdikadir. Many thanks for your feedback as well. Thanks for watching. We'll see you on Friday here on the broadcast. Good morning.